So this is less boring. It was strange when Bronek asked me to do this lecture. And as I know quite well Jean Dubussé because he's a great friend of my mentor, and I knew him when I was in French West Indies for a few years with my boss working there, and he invited him to do the spine surgery 2 weeks a year in our island. So we discussed a lot, and I called him and told him, someone asked me to speak about the story of the CD, and he was enthusiastic. I don't know if you know Jean Dubussé, but he's always enthusiastic. And we spoke a lot about that, and you will see that this is their slides he gave me, and you will see that it's different. My slides will arrange with colors and everything, and this is Jean Dubussé with an explosion of the story. And this is an unbelievable story. It's the story of two men, very open-minded, in December 1982. The first of one of them is Yves Cottrell, who had a huge experience in scoliosis surgery. And he wanted a stable instrumentation and a stable graft to avoid the post-operative plaster. At this time, the child was operated, and after that, 6 months in a plaster. And the other one was Jean Dubussé, who at this time has a more recent experience, had already suspected that the scoliosis was a three-dimensional deformity, and was very unsatisfied with the technique of correction. At this time, there was only two techniques disposable. It was the Harrington by posterior approach and the Dwyer by anterior approach. None of these two techniques correct in the three plane of the space. Cottrell had, at this time, already developed a frame to correct the scoliosis in the 3 dimension with a specific plaster, which the name is EDF. The goal was to tract and to derate and to flex the spine. And he had already developed the transverse system to stabilize the Harrington and to have a brace only for 2 months instead of 6 months. And the great idea that was that he needs this small DTT, so he constructed a small company only to build this system. It was for 1 people. Here is Yves Cottrell. Here is the table to make the plaster, and here is the transverse system he had to the Harrington. The intuition was to build a company, but it was a garage. And Jean Dubussé, he showed us the direction. He had already suspected the 3D deformity. As you see here, this is his own drawing for the scoliosis group in 1973. He had suspected the problem of the pelvic obliquity, and the name he had for the pelvis, you know, with the former talk that the pelvis is a vertebra, and he had understood that in the 70s. He had described in 1973 the dislocation of the spine at the top of the deformity, and described in 74 the crankshaft phenomenon that is now very well known. In 75, he talked about the head vertebra, the cephalic vertebra, and the conus economy. You can see here that is a problem of the sagittal balance. If you are over the conus of economy, it's impossible to walk without crutches. In 77, they begin to use the computer to reconstruct the spine, which is to date very common, and he understands the idiopathic scoliosis on the sagittal view. So in 1982, Cottrell met Jean Dubussé at the Saint-Vincent-de-Paul Hospital. It's a children's hospital with a very small amount of implant. He came with diamond rods, only one bolt, and two type of hooks, open and closed. And Jean Dubussé at this time modified only one thing, the locking system to open the hook because it was boring to use. And then they began to think, to begin the thinking part of the process to develop the philosophy of the CD instrumentation. It was based on the preoperative planning related to the three-dimensional analysis. And January 21 in 1983, they performed the first case. This was a Friedreich ataxia, and Cottrell prepared the open hooks with the blade shift for a right curve, but it was a left one. So they make the surgery, put no brace, it was the first time, and the child stand up at 2 days follow-up. And to make the rod easier to connect with, they use an open hook at the upper level of the convex side, and the X-ray control at T10 post-op show a disconnection. So the conclusion was always ending the construct with a closed hook, and they secured it with two bolts. And for the convex side, they developed the use of the pedicle transverse pinches. So beginning in 1983, they performed one case every week, and at each case, they improved the implants and the ancillary. At the third case, it was idiopathic scoliosis. They decided to implant every vertebra. That's what the first time in the world. Before it was the Harrington technique with two hooks at the end of the curve, and they decided to have each level instrumented. So one hook per level, and changing side instrumented at each level, convex, concave, and the rods at this time were not bent. That was always straight roads. So that was the multi-level instrumentation beginning. And so they, with that, introduced the idea we have to think in three plane and not only AP and lateral view. So they introduced the horizontal plane. Around the seventh case, it was a stiff curve, so to connect the different hook, they bend the rod. And handling the rod inside the hooks, Dubussé saw the spinous process was moving. That was the derotation discovering maneuver. They discovered the derotation maneuver. It was an accident. It was not a thinking process. They just try to put the hook and the rod connected, and they derotated. So they discovered that bending and rotating the curve with 90 degrees, they can restore the profile. So based on that, they develop all the thinking of the derotation, and they build this model of rotation maneuver of the rod. Before, you can see here before rotation and after rotation to restore the profile with bending rod in the AP view. So they describe the rotation and beginning to describe the way of doing for each curve. Week after week and case after case, the strategy and the sequence of the correction by rotation of the rod were defined and specified. I don't know if you have seen this drawing, but it was amazing to discover how to correct the sagittal plane with surgery in the frontal plane. So it's very simple for an idiopathic scoliosis at the thoracic level, and then they describe the strategy for lumbar kyphoscoliosis and for thoracolumbar scoliosis. After that, for double curve with strategy for each curve, and for double thoracic curve, which was at this time the most difficult case. So they described the strategy, and clearly the postoperative results improved. It's improved the patient comfort, the nursing postoperatively, and the quality of orthopedic and functional results. Even at long-term follow-up, you have here a patient 7 years after. Here it's a pre-op, a post-op, and you can see this girl 20 years after with 3 children and still working full-time. So they understand that they have to plan. That was the discovering of the bending X-rays to plan the surgery, to have a preoperative detorsion, and they understand that it's not necessary here to instrument the lumbar curve as it's not stiff, and to instrument only the thoracic curve, no postoperative brace, and here this girl 22 years postoperatively. But very early, 1 year after the beginning, Cottrell asked Dubussé who could do the adult experiment with, because it was only for the children. And here comes Michel Guillaumat, who was a close friend of Jean Dubussé in Saint Joseph Hospital, and he tried to apply the this instrumentation for the adult. But the problem was not the same, as the curve were far more stiffer and the derotation was sometimes impossible. So at this time, he described the lateral pull-up construct. That was the first 3-rod construction, 1983. So you can see at this case with a 3-rod construct and the way to pull the apex of the concavity toward the 3rd rod. And they begin to describe the strategy in the adult for severe and stiff curves. And time after time, they develop new instrumentation, and with the experience, the connector, the lateral hook, and everything. And each time, it was for one case, one implant. They work inside the Sofamo company. And very early, they try to apply the pedicular screw with the experience and the knowledge of Raymond Roicamy, who was the first head of my department. And they use the screws and develop open and closed screws, and then the tulip, and it finished with the new polyaxial screws. And the company at the same time increased. It began to be a big company, and then it was Sofamo-Doneck, and now it's in Medtronic. And it finished with the development of the last generation of implant, which is after the CD, that was the CD Horizon. And after the CD Horizon, which is the same but more simple to use, it will be the CD Legacy. And now it's used every day largely all over the world, and it's begin in the very small institution. It's still the basis of all types of modern posterior instrumentation and developed by many companies now. That was the posterior approach, but at the same time, in the 90s, they developed the anterior surgery, and that was the anterior instrumentation with the CD-OPF. And don't forget that also at the same time, they think about the pelvis. And the development of the pelvis anchorage increased with the pelvic fixation. At the initially that was staples, and that doesn't work. And now it developed the sacral screws, and after that the iliosacral screws, who are put through the alar directly to the body of S1. And now we have this implant with the iliosacral technique, not very widely used, but it's very useful for the scoliosis in neuromuscular pathology to have a very good anchorage on the pelvis and to move the pelvis to put the spine on the right position over the pelvis. It allows to correct the pelvic obliquity. It allows this child to stay in the sitting position and not bending at the same time. So Jean Dubussy insists to finish with this Sufi proverb is what you give belongs you forever, and what you keep for yourself is lost forever. Thank you.